So coming up next, we have, and my notes are at the table. I believe it's Dr. Colley coming up next, right? Dr. Kelly. Dr. Kelly Andrzejewski is going to come up. She'll be talking about DBS. And you've got a couple of guests today, too.
I'm actually going to ask my two patient DBS advocates if they want to wander up here a while. That way, we're going to have Mike and Bob come up if you're willing. And that way we can get outfitted if needed with a microphone or just hold the microphone. Okay? So my name is Dr. Kelly Andrzejewski. Some of you who know me, know that I go by Dr. Kelly for short, as I always say, because people always struggle to say my last name, although it's Andrzejewski, in case you're curious. So I'm the medical director of the Deep Brain Stimulation, or DBS, program here at University at Buffalo, or UBMD Neurology, and work closely with Dr. Robert Plunkett, who we just talked about, as well as Dr. Jonathan Riley, who is our newer neurosurgeon that now does our DBS surgeries. He unfortunately can't be here today. I presume it's the green button. Let's try. There we go. So I'm going to talk a little bit about deep brain stimulation. So DBS treats what we call the motor symptoms of PD. Dr. Cloud just talked about a lot of the non-motor symptoms. So DBS doesn't actually treat the non-motor symptoms unless it kind of does so more indirectly, meaning certain non-motor symptoms get a little bit better, like mood and things like that, after people start functioning better after they have deep brain stimulation. But the main things that we're targeting when we do DBS is to help people's control of tremor, the slowness or movement, sometimes the fancy word is bradykinesia, and then the rigidity or stiffness that we see in Parkinson's. In addition, some people know or have seen they may have symptoms called dyskinesias, which are kind of extra involuntary movements that can occur with levodopa use, more so over time, not usually at the beginning of Parkinson's disease when you're first put on carbidopa, levodopa, or what they call a dopamine agonist, like Mirapex, pramipexole, one of those types of medications. So that's why I say it's not necessarily just carbidopa, levodopa, but also sometimes long-term, when people have been on medications for a while, some of what they term dopamine agonists. So this just kind of shows some pictures of some of the equipment or devices that we implant for deep brain stimulation. Typically, depending on the patient's symptoms, we may place 1 or 2 brain leads, which are kind of like wires, and then they're connected to what they term an extension wire. So that comes down from the lead that comes out of the top of your skull, and then connects to what they call the extension wire that will come down and kind of behind your ear, and then plugs into a battery. And we can see a couple different pictures of them, also sometimes called a pulse generator. The one thing I always stress with patients is that everything's under the skin. It's not like you have some sort of mechanical piece hanging outside. That's a lot of people, they think it's gonna, they're gonna see something, and sometimes people can feel a little bit of kind of a bump where the wires are coming down through the side or where the battery is, but that's kind of right underneath your collarbone, so it's not typically too much of a problem. So in addition to treating the motor symptoms of Parkinson's disease, usually the primary indications for DBS surgery is what we term significant off time. That's one of them, or which off time is when people's medications aren't working that well. They're Parkinson's medications. They're more slow, stiff, they're tremoring a little bit more. Some people, even despite medication, we're trying to optimize the meds, adjust timing, add different medications to treat, say, tremors, we still can't completely kick the tremors in the butt, as I say. The tremor is what we term refractory, meaning it may improve a little bit with medications, but it doesn't go away. So even if people's tremor doesn't completely go away with medication, sometimes we can use DBS to really kind of calm it or make it go away most of the time. Sometimes when people are anxious or nervous, their tremors do start to come out. That doesn't mean they're going to stay, or sometimes as their medications still kind of wind down a little bit, even with the DBS on, you might notice a little bit of reemergence of the tremor. People that have a lot of off and on time, meaning their meds keep kicking on and off, maybe they get in 1 or 2 hours of good time in between their doses, those are individuals that might be a good candidate for DBS as well, because it helps I always say it kind of helps smooth the hills and the valleys, meaning the times when you're moving really well and the times that you're not moving so well. I've had patients tell me that, I can only go out for 45 minutes to go to the grocery store or whatever. Otherwise, when I'm at the grocery store, I freeze up. And they're kind of petrified about that. And I would be too, not knowing, or can I go to the restaurant without realizing that, all of a sudden I won't be able to get up out of my chair because my feet feel like they're stuck to the floor. So things like that can always be quite disabling. So it can oftentimes help smooth those bumps, if not sometimes eliminate them, so people are able to function and get out of the house more. Also, some people have what I mentioned earlier, dyskinesias, which are kind of the wiggly movements that can affect the head, the trunk, or any of the extremities. And these individuals can find it very disabling. They can also burn a lot of calories, which is kind of surprising. Even people that have really significant tremor, they can burn a lot of calories. I think we had a patient recently with DBS that put on 25 pounds in a few months just because his tremors burned so many calories. So people that one more thing or two that I just want to kind of mention is people that don't qualify for DBS might include people with kind of atypical forms of Parkinson's. Sometimes we term it Parkinson's plus disorders or Parkinsonisms. Some of those conditions can include what they call multiple systems atrophy or MSA, or progressive supranuclear palsy or PSP, or cortical basal degeneration that we sometimes call CBD. Everyone's different. So that's where you have to work closely with your doctor so that you can work with them, make sure they get the right history to make the right diagnosis. People with significant dementia we usually do not proceed with surgery because it's hard for them to give us feedback or kind of sometimes follow their directions if their dementia is pretty significant, so that we can adequately turn their stimulators and program their stimulators to optimize things. People that may have severe disabilities, maybe bedbound, things like that, even if they are in the on-site state, might also be good candidates, may not be good candidates. And in some people, if they have a lot of other comorbid medical problems, may not qualify. So now I wanted to make things a little different this year. I know I usually talk about DBS, but I can describe to you that it's generally a good thing for people. But Mike and Bob have both had DBS over the last year or two. And we have some DBS patients I know that are in the room too that have even had DBS for 5, 10 plus years. So we're going to hear a little bit about what Mike and Bob have to say about their experience. So, because I think it means a lot more. So, do you want to? So we'll let.
Hello.
Mike? Okay. So we'll let Mike go first. So, Mike, what do you think kind of got better, and how did DBS change your quality of life?
Oh my God, my rigidity is like gone. My muscles used to be like a rock. And my tremors, both hands used to just jump horribly. And that stopped like instantaneously. They just turned it on and it went away. And I used to use a walker. I know it's not supposed to help the gait problem, but it helped me because I couldn't walk without a walker. And I'm trying to think.
What kinds of things can you do now that you couldn't do before DBS?
Oh, I can eat. I can walk around. I can fiddle around with the guitar a little bit. I mean, all things, build models, Legos, trains, all kinds of little intricate things you can do because your hands don't shake anymore, I would recommend it to anybody. I mean, it's a scare. You're afraid when you're thinking about it, and once you make the decision, you're not anymore. You just do it. If you're not happy with the quality of life, of the quality of your life, it's worth doing. I mean, I don't know. I can't remember all the things that have gone. My feet don't stick to the ground anymore. It used to take me 5 minutes to pick my foot up and tap, like just like that. Now it's like, so it's amazing. I don't know if anybody has any.
Yeah. I still remember when Mike is one of our most dramatic, life-changing patients, I will be honest, but
Yeah.
I still remember you walked into our DBS seminar, I think in March of 2018,
Yeah.
and he had a walker and his wife was making sure he stayed steady with a gait belt. Mike now walks independently, doesn't use a walker, and plays with the grandchildren.
Yeah, plays with my I can
He's got,
play with
what,
my
5
grandkids
grandkids?
again. Yep, 5 of them.
Yeah.
They used to imitate me. They like to do what Papa does, you know. And now that Papa doesn't shake anymore, they want to know why, and it's kind of hard to explain to them. But they're cute. They're great. My wife, Barb, has supported me like you wouldn't believe. I mean, I think to support people goes through just as much as the person with the Parkinson's, you know. But then I start tearing up, so I'm done.
I'm sorry. I'm not trying to make him cry, but
No, that's okay.
you know, we get to know.
Thank you.
You know, we get to know our patients pretty well. I mean, it's a big commitment and a big decision to have DBS surgery. You know? But we work closely with you during your journey to try to get the best quality of life. And, you know, it's not just DBS, it's also medication adjustments, things like that. I know a lot of times patients ask, well, do I still have to take Parkinson's medications?
Yeah.
And pretty much that answer is yes.
Because you still have Parkinson's.
Right, you still have Parkinson's. And, you know, like Dr. Cloud talked about, sometimes too, people need it because if they didn't take it, their GI tracts might not work as well. So it's definitely very important we still take medications. And I always tell patients the goal of DBS surgery is not to not take medications. Sometimes we can lower them a little bit, no guarantees, everyone's different, but, you know, the main thing is to improve quality of life.
Yeah.
So. Do you have anything else you want to mention before we pass it off to Bob?
I think Dr. Kelly and Dr. Riley are great. And the two nurses,
Mike.
Rachel and Pat. In the surgery, I told Dr. Kelly that this is awesome or something.
Yeah, at the very end of surgery, he goes, I think you said, this is really cool, or this is really awesome.
I was
so,
like freaked out, right? Because
Yeah.
my hands weren't moving, you know.
Yeah.
It's like, wow, what happened, you know? But it doesn't hurt, you know. I mean, there's a little pressure around the halo, I would say. Yeah, a little pressure.
but we help you get through it.
Right,
and we do use numbing medication.
Right, they definitely do that. So it's, like I said before, I think the hardest part for me was just getting to just say I'm going to do it.
Mm-hmm. And I see that a lot, you
Yeah.
know, that people, it's a big decision to make. It's an elective brain surgery, but there seems to be this kind of sudden acceptance that people have. It's very
Right.
transforming to watch, and I think very special, but it's a big decision, so
I mean,
I understand that.
I couldn't shave. I mean, my wife had to wash me, and it was terrible, you know. So I'm happy. I couldn't be any more happy.
We're happy for you.
Thank you, everybody. Thanks for pretending.
And I'll let Bob go next. So he's a little bit newer to the DBS side of things, but I'll let you give your
Yes.
story.
There goes the Parkinson's
Yeah.
thing going.
Okay. So
I'm
Bob, what-
at a loss for words for a second,
Yeah.
but it's interesting because I was a biology teacher for 45 years, and I can go 45 minutes on anything. But when I first heard from Dr. Kelly about the
DBS.
DBS, deep brain stimulation, I thought, what is this? And then she explained to me that I was going to, she always said she would take good care of me. Well, I looked at it and I thought, this is taking care of me, drilling 4 holes in my head, putting some wires in, a sound system, and a power box.
It's actually 2.
And whatever. Yes. And it wasn't what it could do, I could do. It was what I couldn't do that caused me to want to go and say, I need to do this. And I committed to it. I knew that Dr. Kelly and Dr. Riley and Pat and whatever were all professionals. They encouraged me. And I just said, you're the doctors. I'm the patient. If what you think is best. Now, Dr. Kelly wanted to make sure I knew that it was my choice and whatever.
Right.
But whatever, let me go on to the next idea. What I couldn't do is put a screwdriver into a screw and put it on and put up a painting on the wall. I couldn't use my cell phone because I couldn't tap on the numbers. If I tried calling somebody, I'd end up with 6 different digits that were none of them. I couldn't use it. I couldn't type text. I couldn't. Yes, I couldn't. I'm trying to think of all the things I couldn't do. One of the things I couldn't do is I couldn't take coffee to my wife in the morning. She loves that. And I could take it, but I needed half a cup of coffee and whatever. And I'd walk in, and then I'd come back and bring some more, several trips because you just need to get a whole cup of coffee.
What service, huh?
but-
Right, Karen?
But, and the things I couldn't do, I couldn't write a Christmas card. I couldn't mail, I couldn't make notes and write them down and read them. It was just like this, as Mike said, this one hand was like this all the time. All night I'd do this. I'd wake up in the middle of the night, I'm still doing this. And it was all the time.
Right.
And there were so many things I couldn't do. But then I came and went through the procedure, and I fell in love with 4 people actually, at the same time after I had the procedure, because there was no pain. It was exciting, actually, when I decided, the science is so well of it, so exciting
Biology
to a
teacher.
biology teacher. And so when
you
Yeah,
kind of
but-
realized
yeah,
how
when
much it
when I
really-
realized how much it changed my life. When I went into to have the
Procedure.
programming done after they did the 3 surgeries and they were doing the programming, which is very much like the if you have an old radio and you have to turn it and get it just on the right channel
A
and whatever.
fine-tuning.
It's interesting. It's exactly how it worked. They have when they do the programming, they have you put your hands out and then they pass little bits of electricity through the
electrode, the
through
lead?
the electrodes, yes. And I didn't know what to expect, and they turned on the thing, Pat did, and this is going away as
Yeah.
soon as I sit down
Yeah.
because this is anxiety or
Yeah.
not
So this
exci-
is what I always tell my patients, sometimes we completely make their tremor pretty much go away. And then when they're in anxiety-provoking situations, such as I'm putting Bob through right now,
Yes.
the tremor does come back out. So I don't want you to think that you'll never have tremors again, assuming you're the Parkinson's variation that has tremor.
But if I'm willing to concentrate, that's no problem. And it immediately changed my life because I had been feeling when I couldn't do anything, I couldn't do anything, basically. If your hand doesn't work, it's as if you don't have one. And it's hard
Or
to
in your
work when you
pocket.
don't have one. And anyhow, when I when they put the programming on, I thought, okay, let's see what this is going to be like. And I was like this, and then they started setting different settings, and all of a sudden I'm like this. I'm thinking, is this supposed to be what this is supposed to be? And then all of a sudden, and it hasn't come back. Now it's interesting. My wife says that I was a biology teacher for 45 years, and I did all these lab experiments, and I turned out to be in the end of my teaching career, I was the experiment, and it went very well.
Yeah. Can you comment on your dyskinesias? How the DBS helped with that, and what it was like before versus after?
Oh, what was before? I haven't had any dyskinesia at all right now.
Yeah.
But before, my wife, I didn't know she was doing this. She was taping me, and if anybody wants to see it, she's probably got it on her phone right now. If you want to see it, watching a football game on the
On the
in
couch,
November,
right?
and sitting on the couch, and I had no idea. I realized I was doing a little bit, but when I saw on the thing, I was basically looked like a drunk sailor, and
Wiggly.
It just went away. So thank you.
Well, thank you for being so brave.
Yes.
So
Well,
these
it's
two
brave.
are some of the many very talented and amazing Parkinson's patients I get to work with, and deep brain stimulation patients. So it's always nice to see them
My
every
gait
time
was
they
pretty
visit.
bad, but now I can even dance.
Yeah. so thank you very much to both of you. So I think that kind of times out perfectly for questions. So if you guys have any questions for
Any questions?
Bob or Mike as well, if they're willing to answer, we'll certainly do our best.
Mike, how old are you right now? How old?
58.
58. That's the only question. Are you single?
No, he's got an amazing wife. They both do.
How well do you move?
You want to?
Well, I was just gonna say because he's 53 and he had the operation done too.
Yeah.
So he,
So there's not a specific age restriction other than when it's treated in for some children for a different condition called dystonia. Usually it's 7 years and up, but that's obviously much less common and it's not Parkinson's.
So the procedure, so give us just an example like of a procedure and how long they're in a hospital and recovery
Sure.
and stuff.
So typically, there's a little bit of a process. I'll just kind of give an abbreviated version from start to finish. So once a patient will come and see me, and then I say, I think you're a candidate for deep brain stimulation, we do something called off-on testing as kind of the first step. And that essentially involves the patient coming in with not taking their medications for about 8 to 12 hours before. And then I do what they call a Parkinson's rating scale, which some neurologists also do out in the community. And you look at their finger tapping and opening and closing and turning their arms back and forth. And we kind of grade their tremor and their walking. And then as long as I see a good change, once you take your medication, your levodopa medication or any other medications, and then we look to see that there's an improvement in that score, meaning your tremors are less, you're less stiff, you walk better. Those are all positive things indicating you'll be a good DBS candidate. So after that, then typically we do what they call neurocognitive testing or memory and thinking testing, I kind of call it. And essentially that's just to make sure that there's no significant evidence of dementia, because we want to make sure people understand also what they're getting, what they're going to be going through, and that they're able to tell myself or the neuropsychologist and understand the procedure, because it is an elective procedure. As long as there's no significant concerns on the neurocognitive testing, then we'll have you meet with Dr. Riley, our neurosurgeon, to kind of have a consultation, and he'll go over a little bit more of the surgical details, risks, and things like that. And then after that, you would have an MRI of your brain to make sure there's no concerns. And then Dr. Riley will use that image, and on the day, we'll kind of go next to the day of the surgery. Most of our surgeries are done in the morning, sometimes in early afternoon we start. And what we do is you will come in that morning or early after or late morning, and have what they call a frame placed on your head. So I don't have a picture of that. If you come to the DBS seminar, which I'll show you information on in a minute, you can learn. You'll learn a lot more in details. But essentially, then we would put this frame on, and we do a CAT scan, and it allows us to know exactly where in time and space that frame is. And that'll allow Dr. Riley to know exactly where he's going to put the wire, because he fuses it with that MRI image that that you got usually a couple of days to a week or so or more prior to the surgery. And then after that, you would go up to the operating room with the frame on, and we would give you some medication to make you kind of sleepy, so that way you're kind of don't really care what's going on. And then that's when Dr. Riley would make the incision and make the very teeny tiny drill holes so that we can access your brain. He would then, depending on the patient, we may be putting 1 or 2 leads, or sometimes I refer to them as wires because people understand what a wire is. It's a long, pointy thing. And then at the end of the lead, there's 4 contacts that allow us to deliver electricity to the brain. So for the first surgery, we just put the lead in 1 or both sides, and then typically you'll come back 2 weeks later and have what they call the extension wire, which is the part where I was talking about. The lead wire comes out of the top of the skull and will connect to the extension wire, runs down behind your, down the side of your neck, all internalized, nothing hanging out or anything, and will connect to a battery where Dr. Riley makes the second incision down just below the collarbone or clavicle. So that second surgery will be about 2 weeks later. That surgery is done as an outpatient procedure. You are put under general anesthesia for that. Just, you don't need to remember that. For the first part where they place the leads, we wake you back up for the kind of second part of the procedure, where I always say we listen to your brain cells firing or your brain cells talking. And that allows Dr. Riley and I to know and make us more happy about where we're putting the wire, that we're definitely in the area that he planned on it. So it's just a little extra reassurance. And then what we do is we temporarily deliver electricity through kind of a temporary extension wire from our little programmer, just to make sure that we see good benefit from the surgery. Because if we don't, then that may mean that Dr. Riley and I need to kind of have a little small conference in the operating room and decide if we need to move the electrode. So we haven't had to do that for any Parkinson's patients. He's a very smart, very precise man. You're in good hands, I will tell you that. I have nothing but good things to say about Dr. Riley. And I'm sorry he can't be here today, but he had a surgery that was kind of an emergency that he had to go to. So he's a hardworking man. And then typically you'll stay overnight once we're done with the surgery and you're all closed up, and you'll go home the next day as long as there's no complications. So that's kind of the process. 2 weeks after you have that battery placed is when we would turn the stimulator on typically. Sometimes a little bit more, sometimes a little bit less, just depending on scheduling and availability and things like that. And we're very much a team approach. Not only do I work closely with Dr. Riley, but I work closely with my 2 nurses, Pat Weigel, who, as you can see, was one of our founders of the Western New York Parkinson's Foundation and has been doing DBS programming for about 20 years. So just to kind of give you an idea, DBS was FDA approved in 1997, and Dr. Plunkett and Pat were doing DBS surgery starting, I think it was in 99. So we had this technology in Western New York, and some of our patients have had DBS that I see for 10, 15 plus years. So it's not something that stops working, because sometimes people will say, oh, is it only going to work for 5 years? No, it's going to continue to work. People will still advance in the disease, meaning your symptoms will get more stiff and slow. And I think these gentlemen can say even in the past couple of months since their DBS systems were turned on, we've had to make adjustments. And I think Mike especially knows this. He's had it a little bit longer. And now we're fine-tuning things, and he comes in and he says, I can't play as well with my guitar on this one. Can we make the tapping? And I go up a little 0.1, 0.2, and he goes from this to big and wide. Do you want to show us, Mike? Sometimes we joke, are you getting tired just because you keep doing and testing yourself when I go up a little bit and a little bit? And then he tells me when it's good enough. But, this is where sometimes people get so perfect, they almost forget what it was like beforehand. So not that I want to downplay that, but we get to fine-tuning little little minuscule things, but by that point, that's how much that means to patients. So, sorry, I went on for a long while for that question, but that kind of gives you an abbreviated version. Learn more if you come to the seminar, and I'll show you the info for that. That's our team, by the way. So it's all of our team. So, and this is the next DBS seminar. There's also some cards that are out on the table with all the Parkinson's Foundation. That should still probably be enough out there that you can grab to take along with you.
Just a real quick question. Along with treating the tremors and the dyskinesia, dystonia is a big problem with the cramping with the feet and the hands. Does the DBS help with that as well?
Yes. Sorry if I didn't mention that, but yes, it helps with dystonia as well.
Hi, I have the only question, one little question. Does your insurance cover any of the surgery?
Yes.
It does?
So, yeah, it's
Oh.
been FDA approved, like I said, since '97. So insurance does cover it. That doesn't mean, obviously, we know that everyone's plans are so different.
Right, right.
So some people might have no out-of-pocket costs. Some people might have a little bit of out-of-pocket costs. So typically when people are concerned about that, which is often, what we do is Dr. Riley's secretaries are able to give you some of the codes that you can call your insurance company and try to find out what kind of out-of-pocket costs there may be.
Okay, the only reason I asked that is because it's considered, is it considered an elective?
Yes.
So that sometimes makes a difference, but,
Yeah,
but thank
no.
you.
Yes.
Dr. Kelly,
Yes.
just a softball question. Maintenance on the system.
What was that
Is
again?
any maintenance long-term on the system?
Yes, I did mention that. So as long as generally we quote about a 5 to 6% risk of infection over time. We've only had, I think, one infection over about 35 plus surgeries I've done with Dr. Riley. So that's actually less than the national average. But it's a risk. You're putting a mechanical piece in you, or pieces. It's not very common, but we do make you aware of that risk before you proceed with surgery. We don't typically, unless there was an infection, have to replace the electrodes or the extension wires with some rare instances. Sometimes if someone has a fall or anything, there can be kind of a dislocation or dislodgement of the extension wire from the battery or the extension wire from the lead. That sometimes makes us need to kind of go in and do a revision. That's very rare. Other things, the batteries. So typically batteries, there's 3 different companies that make DBS, which we could get into more detail. If someone was a candidate, we would discuss this more with you. But depending on the company, there's a little bit variations in their batteries. Some are rechargeable, some aren't. Most of the time, we don't start off with a rechargeable, but it depends on the company. Some of the companies, I think there's one of them that only has rechargeables right now, we were going to, as I say, install or implant that company that we would likely do the rechargeable, because there's factors that come in about MRI compatibility in the future, things like that. But that's something that Dr. Riley and I would kind of talk with more. But typically, on average, for the most Medtronic, which is the company that's been around the longest, their batteries have to be replaced every 3 to 5 years. And if we find that people go through a battery faster than that, then we have the discussion about whether to put a rechargeable battery in, which lasts 15 years but commits you to recharging roughly for some people every day, some people every 2 to 3 days. Usually if you wait an extra 3 days, you might be sitting there a little bit longer. That's what patients tell me. You might be sitting there for about 45 minutes to an hour and 15 minutes versus sometimes 20 minutes if you do it every day. But we don't routinely put that for that company, put the rechargeable in first. But everyone's different, and that's a discussion you would have with Dr. Riley and myself about, now that there's actually 3 different companies out there, what version do you want of DBS? So we didn't have that choice before. Now we actually do. So
Well, thank you, Dr. Kelly.
thank you very much.
And thank you, Mike. Thank you, Bob. That was really quite stirring. Bob, we want to see more of that dance step.
problem with this is my wife has the remote. It turns it off, and she's always telling me, hold it. She gets anything she wants. Okay, you're going to take it away from me.
But she doesn't turn it off until you've gotten the coffee to her.
She would never turn it off.
Well, thank you. Thank you very much.
Oh, I promised you I'd dance. Right?
We'll get you later. Okay. You know, it's remarkable how many faces are becoming familiar out there, and it's great to see everybody. It's good to get to know more and more people in the community. And thanks for being so friendly and coming up and chatting and introducing yourselves. I really appreciate it. Right now we have Cynthia Pagato, who is behind this marvelous creation, and she's going to lead us in a little bit of a movement exercise for a few minutes, and then we're going to take a break. And I actually have to look at our schedule here, too. We're going to come back at 11 o'clock, so it's going to give us a chance to get up and relax and go get some more coffee and visit the exhibitors. But let's take a couple of moments first and get a little movement.
Good morning. Let's make a big yawn. Again, ready? Stretch. One more chance. And now a nice, great big breath, and coming down with a sigh. So, 2 more times. And one more time. Beautiful. Thank you. You know, it's amazing. 5 years ago at this event, I launched my PD dance program and introduced it to all of you here. So I just want to thank the dancers who have come to my class, because as soon as you enter in through the doorway into my class, you are a dancer. I make sure of that. Trust me. So I just wanted to say that the PD dance program that I teach, it's therapeutic, because I have specialized training in delivering movements and activities that are right for Parkinson's symptoms. But it's also a true art class. It is not a support group. We do not talk about Parkinson's. We come and I teach you as dancers, as a dance class. And so we get the physical, emotional benefits of it. We also get the artistic expression that we get to develop within ourselves, things that sometimes surprise us. And then, for those who care to take this part of the journey with me, we have done many public performances with the work we create in class. We've performed at Canal Side, global water dances, where we talked about, through our dancing, the toxins in the environment and how that makes us really interested in being advocates for clean environments, because possibly that has played a part in our symptoms now. We've performed at Silo City. We've performed in all different places in our area. And so, by coming to dance class, and if you choose to do these extra projects, and they're optional, you can also be advocates. We are really raising awareness in our area through our dancing of Parkinson's, what it is, and what we can do despite it, okay? And so I just wanted to talk about that for a little bit and let you know that there are some very special programs that I've developed with the dance program, and I also teach 2 Parkinson's exercise classes a week as well. I have some copies of a flyer, so if anyone's interested, let me know, and I can give it to you. I didn't get it to Chris in time for him to make a lot of copies, so but I can get them out to you. One of the programs that I'm really proud of is Art Moves Me, and it's a program that I dreamt of for 3 years before it came into fruition, and it takes place at the Birchfield Penny Art Center, and it's our Parkinson's dance class. It is open to the public, so you have to register and get a spot. But the Birchfield Penny just sent this flyer out to all their members, Healing at the Center. And it is our Parkinson's dancers in the flyer doing a dance at the Birchfield. And this past year, I felt moved to create a visual artwork. And I'm a dancer, so I'm going beyond my usual scope with this. And I created an artwork where the dancers in my class were given material, linen, to pull and manipulate and create shapes with that they knew were going to go into this artwork. And my observations of being a Dance for Parkinson's teacher for 4 years was manifested in this 2-panel sculpture that I created with their stories, your stories in this artwork. And it was exhibited for 3 months at the Birchfield Penny. And it's 2 panels. I wanted this thing to be big because with Parkinson's, we're always trying to move bigger. And so it takes 15 linear feet. So it's quite a work of art. It is going to be displayed at the Art Park Gallery in July. And then it is moving to a permanent home, unless it finds other stops along the way, on the Buffalo Niagara Medical Campus. And so I'm really excited that the work that we've done in dance class is expanding in these ways. And so when it gets installed at the Buffalo Niagara Medical Campus, we're planning a presentation, and neurologists are going to be involved, in case you don't know that yet. You will be. And hopefully med students. And I was just thinking, as I was listening today to Dr. Cloud talking, and all the incredible questions that have come up about, well, have they researched this? And what about this? And what about that? And we had a whole lot of questions, and I hope you'll help me make a tally of them later. Dr. Cloud, I'd appreciate that. Because when I go to present navigation, the artwork on the medical campus, there hopefully will be med students attending, and the Parkinson's dancers will be dancing. And I would love to inspire more med students in an act of advocacy to possibly consider specializing in Parkinson's research. I don't know, do we need more researchers? We do. Okay, so that's an interesting way of how the dance program can really make an impact in our community. And those are the type of things that you may be surprised to find when you come to my dance classes. So for now, I just want to give you a little bit of action. We did an immersive workshop and a couple months of studying flamenco dance in my Parkinson's dance classes. And flamenco has so many good things for our symptoms. And so I invite you to do a clapping rhythm with me. Now, I understand that we're on carpet. So I would like you to uncross your legs if they're crossed, because I'm going to need you to stamp your foot. And it goes like this. There's a foot stamp, and then two claps. Okay, so with me. Part B. Thank you. And part C, stamp, clap. Beautiful. So that's kind of some of the fun we have in flamenco class. Could we please have the habanero music? Can we make it louder? Just follow. Wrist circles. been great. Thank you. And there's one thing I can say. If you come to my class, we're going to have fun. All right, so the World Parkinson's Congress is taking place in Kyoto in June, very soon. And I have arranged we created a crane dance here with the Parkinson's dancers, and we created a crane. So again, with Parkinson's, we try to move big. And I made the biggest crane with my dancers that we could make with a single sheet of paper. So it's 107 inches square, and it came out into a crane of a 7.5-foot wingspan. And the reason why we needed our crane to be so big is it's taking our 1,000 crane Wish to Kyoto. Now it's going digitally because I'm not able to get there, but maybe I can get to another Congress, I hope so, and be an advocate. But we are wishing, of course, that the medical researchers make huge progress in Kyoto as they convene and share ideas on treatments and pathway to a cure for Parkinson's. And so our crane is very special, and he had to be very big and very strong to take all our wishes all the way to Kyoto. So I invite you during any breaks to come up to the crane and get pictures taken and somehow share them with Chris or me so that maybe we can send those to Kyoto too, along with our wishes. So I don't know, Chris, am I out of time? Okay. I have video footage, and it's 2 minutes and 44 seconds of our crane dance that some of you in this room performed. We took it to the Buffalo Japanese Garden, and we performed under the cherry blossoms. So whenever you think it's a good time to show it, we'll show it during lunch, all right? So anyway, I thank you very much, and I will also be doing movement and music during lunch, so if in between salad and dinner you want to move with me, we'll get to do that too. But anyway, thank you so much.
Okay, everybody, let's take a break. We'll pick things up again about 11 o'clock. Thank you.